The three of us are going to talk a little about digital technology. It seems to be the focus in dentistry, and related, of course, to our interdisciplinary and the team. Does the team do this? How do we do it? Or is digital taken over as the team? So, digital, we're at the beginning for most of us of this long, winding, tortuous road, and it's convoluted, it's difficult. But it really is kind of exciting, and it's confusing, but it is rewarding because we're doing things much more simply, we expedite the process, and we're finding out the team is an integral part of this. So it really works for us. The team, as you kind of know, Maurice, Ronald, Henry, and I, but really couldn't pull it off without Dr. Guy Cabral, Dr. Christian Coachman, and Maha with us, just a whole group of people who are here, and sitting in the back is Dr. Abtin, who's our oral surgeon resident. So we're going to be talking about digital in the single unit, and of course, where you get just remarkable information leading off the adjacent teeth, and you can do just remarkable stuff. And then, of course, you get into one of these where you have no landmarks left, and you can now relate it to other aspects that we can superimpose. So digital, it is the future of dentistry. We're going to look at beyond 3D. Digital is actually 4D. Remember, most of what we do is photographic, it's two-dimensional. Even digital smile die design is two-dimensional. Beyond that, we have three-dimension as we began to use the CBCTs and other kinds of scanning devices. And the real issue that's really missing for us is dynamics, the fourth dimension. It has to be moving, and that's kind of where we sense it going. So 2D, 3D, 4D. 2D is kind of what we're used to. Two planes, that's all. It's done by light, and we see things mostly in 2D, and that's what we're used to. Photographs that facilitate two-dimension, we kind of create the illusion and try to read into it three-dimension. Remember, it was only with the evolution of the CAT scan and then the CBCT, sound radiation, and other forms of radiation that we got this ability to do three-dimension. And that was exciting. I mean, for all of us, that was a great moment because it kept us out of trouble and allowed us to do just so much more. A remarkable process. And then, of course, we now are beginning to see four dimensions, meaning we have live performance captured with waves. We track that surface, we texturize that surface, and we can now superimpose this on the 3D images we have. So when someone's smiling, it's not at a point in time, or 3 points in time, it's constant. So this is kind of where we're going. It changes dentistry. You can see how we have the ability to superimpose skeletal form accurately today on facial form, and then put in third dimension or third-party planning software and go through the process of taking this across, integrating it into the treatment plan and into the final design of the prosthesis. Really kind of exciting. Quite different from just two-dimension that we're used to. And we try to create the illusion that we were picking up mobility, dynamics at different points. So we take pictures at rest, an interim smile, wide smile, all kind of key aspects of developing a case. And this is a 2D digital smile design, really developed by Guy Cabral and Christian Coachman together while in our office, and made it available to just all of us. The illusion again of 3D, but very effective at two-dimension. So this is her upper with no show. She's a patient that I treated 20 plus years ago. Crowns are good, but she's older. And we're going to go through the process of giving her longer teeth. How much longer? I can't kind of go to Guy, just make him a little longer. I wouldn't know exactly how. We digitally plan it, and we know that, we're going to add 2 millimeters to this, 1.75 to that, 1.5 to that, only 0.5 to that. It's a very accurate transfer of information, very integral to all that we do. He has this information. He can take, this digital treatment planning into an analog wax up, and I can then make that into a trial smile and evaluate, make modifications to that, settle it with the patient, and we really develop our total treatment plan. So digital into the analog wax up, and then take it into a prototype, what we used to refer to as temporaries or provisionals. They really are prototypes because remember, it's not just in the mouth as a try-in to cover the restorations. We're going to use that as the prototype to replicate in the final restorations. So it's more than just a provisional today. You can then go and take that prototype and have it copy milled basically in whatever particular machine you like in particular products. So these are Emax blue blocks that are milled. We've got a couple of zirconia frameworks on either side for the bridge work, and on these tiny little anteriors we did Emax pressable for the kind of accuracy of fit that we utilize. We then can put them onto casts because we're used to it, and we're still working at this stage on casts, and we cross-mount these casts so you can have the temporaries related to any particular arch, and we can have any particular restoration related to any other one. So you can see the wax up related to the lower, and you can finish this lower and develop the upper against it. So utilizing all the technologies with all the different products, and we get this out of it all. And we take it through this, develop the integral colors to them, and this is a final prosthetics, digitally planned, and then replicated, manufactured according to real specific dimensional needs for this patient. So this is really 2D. So, kind of interesting, but it's basic restorative dentistry with digital overtones. The smile design initially, the information transferred, where we could then CAD/CAM mill it all and develop it and just finalize it in the office. And this is what we'd planned to do, and taking her from there to there. Nothing dramatic, not a remarkable case, but technology at work. So we're going to go to the opposite extreme. Let's look at cases. There's so much we can show you from single units with different systems. But we're going to actually dwell for a while on digital dentistry, team limitations. Are there limitations that we have, all of us, even working together, utilizing this collective knowledge that we all have? This is a gentleman, quite interesting. We've been watching him in the office. He's failing periodontally. It's refractory periodontitis. And we've been kind of holding him together. And you'll see what he looks like. No plaque. This is the CBCT done with our 9300. And you can see, taking it straight off their software, we can rotate it, check it out immediately. It's very software friendly, makes it easy for us to check it out almost immediately with the patient, as opposed to transferring it to different systems that may be third party and do different things. So that's kind of nice.
One of the aspects of working together is understanding the patient's expectations for therapy. This gentleman, obviously with many, many years of periodontal work at our office, the attempt to maintain his dentition. And for David, Henry, and I, the whole team, really our first opportunities with the patient is to explain to them the needs of oral health and maintenance, periodontal health in particular, and we try to keep them dentate, keep them with their teeth. That's our job. That continues to be our role. Unfortunately for this gentleman, as part of his occupation, he's a singer. He had teeth that were become extremely mobile. He could no longer feel comfortable singing, and also he was uncomfortable masticating food. And you can see the amount of disease that we were dealing with. And the decision now becomes a very difficult one that will be discussed during the program, I'm sure, by many other speakers. That very, very complicated decision about whether to keep teeth or not, the timing of implant placement, and whether or not to join teeth and implants in that reconstruction. And this continues to be something that's a focal point for many of us. And we, I would say, we anguish over that decision till this day, as our training really is started at University of Pennsylvania with periodontal prosthesis, really maintaining teeth for a lifetime. And now we transition these patients into an implant-supported restoration. How do we do that in the best way? How do we do that collectively working as a team, taking the technologies that David's showing you and then processing them, including digital smile design, including the CAT scan images, the 3D softwares, the planning softwares, the surgical guides, all the way through to the final process. One of the first things that we wanted to do is this gentleman just could not accept a period of time in a removable prosthesis, something that Henry first published on back in the mid-90s in IJPRD when he did one of the first series of cases on immediate loading in the maxilla. At the time, it was something that just wasn't done. Dr. Schnittman did it in the mandible. Henry was the first few cases that was published in the maxilla. And now we're doing it rather routinely. So we've taken giant steps forward in our ability to actually transition patients from function of teeth to the immediate function of an implant-supported prosthesis. But how do we do this so there's no fault lines, there is no errors in the processing? We take no risk. We want to make sure there's accuracy in the plan. So what we will do is look over this 3D image, we'll take it to the 3D planning software, and I'll review it with Henry, with David, with Guy, with the laboratory technicians, and say, is this the number of implants that would support a fixed restoration? What's the quality of the bone in this area? How are we going to manage the angulation issues? How are we going to manage the provisional restoration? And these are all issues that must be addressed, I believe, prior to the surgery. I believe the surgical modality for us really is based upon the decision from the restorative plan. Without a restorative plan, the procedure becomes more guesswork. And I don't believe that there is any longer an aspect of that in our practice because of the technologies that are now made available to us. So we can look at positioning of the implants related to the existing dentition. And of course, we're going to relate it to what David called the digital plan and the prototype. So digital smile design is now incorporated into this from the very beginning. It's not incorporated after the implants go in, but it's done at the very beginning of the case. There has to be modifications throughout the process, but it gives us something to work with. It gives us a working design, if you will. It integrates potential aesthetic changes into the real dimensional treatment planning, and of course it does not stop, because it does require now clinical execution and modification must be done, obviously, throughout the procedure. But it is a good starting point. It gives us an aspect of what's been lost over time. The elasticity of facial form, the lip drape changes over time. This gentleman now in his 50s has a different smile than he did as a 20-year-old. Are we going to give him back the smile he has, or are we going to enhance the smile that he wishes to have? And these are all things, again, just not about function, it's about the design of what we're going to give him to enhance his overall facial appearance. So this is all done early on in the case, working with the laboratory technician, with David, with Henry, with Ron, with the entire team. We can show the patient what these subtle changes may look like in color, shape, texture, form, and how they will look when he's smiling. So the digital age obviously requires us to not only plan the cases from a bone and foundational standpoint, but to incorporate the bone, the anatomy, the soft tissues, the lips, with the design of the restoration from the beginning of the case. We're going to take this and now we're going to create the second stage is once we approve everything, the patient approves the mock-up, the prototype, the digital smile if you wish. If the laboratory, Henry, David, and I agree upon the number of implants, the location, direction, trajectory of those implants, we can now send this off and get a computer simulated surgical guide, and we can get a stereolithographic model to work with. We digitally plan the case, and then we're going to consider at that point the CAD/CAM mill prosthetics that will go on top of it. At this point, we're going to go ahead and utilize not only the planning of the implants, but the planning of the abutments as well. And this is something that Henry really brought to us many, many years ago with the concept of one abutment, one time.
One of the themes of the meeting, as you all know, is today's innovations and tomorrow's solutions. Well, this particular concept of immediate loading was the innovation of the early 90s. We started utilizing it almost 25 years ago. And you can see how the solutions continue to evolve. And digital dentistry certainly has been a part of that. Designing treatment, carrying it through, and getting us to stages where even the program that you'll see today are many different clinicians approaching the same challenges with different solutions. So one of the aspects of actually treating a case like this is not only, as Maurice mentioned to you, how many implants, what size implants, what angulation implants, but once you actually get the implants in the right position based on the plan, how do we actually go through the restorative protocol?
I don't think so, because the other one wasn't working.
We got them exactly where we want them, and throughout the day you'll see many different clinicians today using their particular team workflow to either place their abutments, as you'll see in this particular case, the implants are placed, and then we can actually go ahead and think of terms of how to manage this tissue complex in the most efficient manner. One of the factors that we've looked at based on the work of Abramson from 1997 that looked at connections and disconnections of components multiple times as you go through the workflow of treating implant dentistry. Where we took from that and what we took from that is the fact that, well, if we can minimize these connections and disconnections of components, we can actually minimize the kind of trauma that goes to the peri-implant tissue. So what we try to do for these types of cases, if we can, based on the plan, is actually choose the final abutments, and we put them on at the time of implant placement, with the idea if they line up as we planned it, we never have to disconnect them. This is for one abutment or multiple abutments throughout a case. One of the key features, of course, is to have either refractory dies so that we don't have to take these abutments off. We can then transfer them with snap-on components, so you don't have to use cord and traumatize the tissue. So minimum trauma. And then take these kinds of cases, transfer them to the laboratory, and do all our work without actually having to remove these abutments, put on transfer copings, and in any way traumatize the peri-implant tissue throughout the healing phase. You'll see many different solutions throughout the day where today we can actually plan digitally the final CAD/CAM abutments prior to implant placement. So there's many different ways. There's a lot of exciting work that we can do and plan out together. Going to the mandible, in this case, a little bit, the flaps are elevated, and the implants are placed again according to the plan with PRGF and bone grafting. So in combination, and yet we can still use the one abutment, one time concept to place our final abutments, take our impressions, and make our temporary restorations. And you can see here as we go through the initial day of treatment, taking this patient from a full upper and lower anterior deteriorating situation to an immediate temporary restoration.
So one abutment, one time has been an integral part of so much we do. It makes our lives quicker, easier, expedites the whole process very effectively. And this is healing at 3 months. You can see a little of the bone grafting coming out of it that we supplemented with, but really quite dramatic healing and, of course, stability with the cross-arch stabilization. Go through the bite registration or verification from the temps, just using, again, the snap-on components and building up with composite. And then we fabricate, in this case, not CAD/CAM milled, but a metal trine that we cast and re-verify that bite so that we really have minimal changes. And of course, remember, we actually digital smile designed this, took it to an analog, developed it. So we're pretty close in the metal to what we want, and Guy knows and Christian knows exactly how we intend to finalize it. White and pink over PFM, a topic we've been talking about now since 2007, and really become very much part of the way we handle these big cases, but we have to plan them deliberately. And one of the things we've introduced really is that pink-to-pink interface. This interface to the remaining soft tissue, we actually reduce the bone vertically so that we can hide this interface vertically beyond the perimeter of the lip, behind the curtain where you can't see it. So it's kind of a different thought process, the ridge reduction, not just for placing implants, but to hide the prosthetic phase. And obviously digital smile design is a critical aspect of that, knowing where that lip is on the skeletal form that we're looking at three-dimensionally. And just looking him sideways from a sagittal view and directly on. And kind of a pretty case we're proud of, I think, nicely executed, and looking at it long term. So the team with digital, really simpler, expedited execution and replication of what we planned. So you always want to see post-op. We like to show you 3 months, we'll even show you 4 months, but let's show you 7 years. That's a pretty good interim period. So this is 7-year x-rays. That's the right side.
The patient actually came in to the practice and was concerned about the fact that the bridge was loose. Some of the things that I think that we do also have to understand is at this point, with all the technology that we have available, is the confusion over material selection, the confusion over what type of materials to use, whether or not to do this with artificial gingiva, hybrid prosthesis, or any type of removable prosthesis. One of the decisions that was made, as David mentioned to you, is it was a traditional ceramic metal restoration. And because of that, some of the decisions made with the laboratory was to separate the case into 3 segments rather than having it fully splinted. And when the patient came in, they put it on David's book because they thought that the bridge just, a couple of abutment screws were loose and they needed to be retightened. So, put it on David's book for that. And the patient came in, David said, I think it's in the wrong chair. This patient, you did the implants, look what happened to them. So I said, thanks, David. So obviously we took a look and saw that some interesting things had occurred. A fracture of a screw, a fracture of an implant on one side, and obviously, as we said before, the separation, maybe the non-splinting of the entire bridge may have had something to do with that. As we say, over-engineering of the case, having a cantilever on that section. We really don't know. These are things that we need to understand and need to be concerned with. But 7 years, is that long enough? How do we manage that? While we were looking at the left side of his mouth and planning on taking out an implant, replacing it, he came in a few weeks later and said, now the right side of my bridge is loose. And we put him in David's chair again, hoping it was the abutment screws.
Always my chair.
But this time, again, the opposite side, the contralateral side, had the exact same situation. Fracture of the abutment, fracture of the screws. And now the dissemination, the forensics in dentistry to look at where did it go wrong? Where did a case that was so well planned go wrong? Was it material selection? Was it allowing just the laboratory to make the decisions on the separation and the splinting? Do we know exactly why? These are things that we have to continue to look at. If we take a look at this in the mouth, some of the interesting things are that there is no bone loss around the implant, but the implant has given and fractured. There's a biomechanics. We can go into an entire day lecturing, trying to find out what exactly went wrong. We could not remove the screw fracture on the distal implant, so we need to replace these. Luckily for us, there was bone available to take out the 4mm implant and to place in a wider diameter implant. And we took this implant out with a trephine. Today we would use a reverse torquing tools that are available to us to minimize trauma to the socket. But if you take a look at the amount of bone that is retained in this person, even after fracture of the implants, quite interesting. Not a tremendous amount of bone loss, even after removal of the fixture. And removing implants and replacing it and redoing these things are going to be, unfortunately, part of our future. There's no doubt we're going to need to manage these types of situations. So what did we do? I looked at David. I said, I don't want this to happen again. We decided to over-engineer the case. We went from 8 implants to 10. We added 2 extra implants on both sides. And while the posterior case was healing, waiting about 2 to 3 months before David can then get back in there, this gentleman came in and fractured the anterior bridge. This one truly was to be put in David's chair. The framework fractured. So is this person a bruxer? Is this person a clencher? Does he have strong masseters? More than likely, we're dealing with that type of parafunctional habit. So while the posterior implants were inserted in there, now David has to deal with reconstructing the prosthetics of the anterior bridge. And this time, material selection and splinting of the case has to become the onus of the team. When David says to me, do you want me to break up the case again and use ceramo metal? I told him that's his risk if he wants to do that. But we want to do it with something that's going to last the test of time. The soft tissue heals. We have bone, we have enough implants, we have keratinized gingiva 360 degrees around these implants to maintain them for the duration. They're placed appropriately for the restoration in terms of restoratively guided implant placement, always based on the guide. And now he has the foundation to really set up whatever he wishes with the laboratory and with material selection. So at this point, we really hand off the case to the prosthetic team. Now, David, at this point, I believe it was Guy and Henry, and let them decide upon how best to manufacture a final restoration.
So 10 fixtures should be enough. 10 fixtures may be cross-splinted. Let's look at our options. It's a little later in our development. You know how we did impressions at that particular juncture. And now we can do traditional again, generate a model, and from that model you can go through the process of developing, from an impression, developing a model. So you can get your traditional analog model that we're used to working, and the wax up, of course, is already done. It was digitally done, and we can replicate it now on this model digitally. Quite amazing. You can also do digital impression making. We can do it directly intraorally with some form of scanning device and take it of all these. From that, I can generate an analog model. And of course, you can take it and generate a virtual model today. We don't have to work with analog. Kind of confusing as you start looking at this. So you've got direct digital, traditional, and then you actually have another component. We can actually take this impression that I made and I can indirectly scan it out of the mouth, and then from that generate models, either a virtual model or an analog model. So you can kind of interface digitally with just any particular point. And we're trying to put them all together as we go through this process. So 2 kinds of models. We're becoming much more comfortable working this way. It doesn't have the same tactile sensation, so you have to put it back into the mouth to get that sensation that we're all used to. Final prosthesis. I mean, do you want to deal with Maurice again? Not happily. I mean, it's always my fault. That's why I do drink scotch. So final prosthesis, give me some ideas. I mean, let's see if we can do it digitally this time. We planned it, we executed it the last time in PFM. We can do PFM today digitally. We can make the metal frameworks digitally, really develop them strong enough, we believe, to support this. We believe. We could do it in monolithic zirconia. You can think about it, and we can do a metal substructure, with individual lithium disilicate or Bruxa crowns, zirconia crowns. Or we can actually do an Atlantis metal substructure, chrome cobalt, and utilize denture teeth, or we can use composite or acrylic on top of that. I mean, just options. You mustn't forget, this guy, when he first came in, couldn't keep his teeth together. He would have extricated them. So he was used to being very gentle with it, and he's destroying literally everything. And I look at them all, and there's really no give in the system, is there? None. Something is going to go. It's just when. So we're actually going to make several at the same time. Really amazing, articulation today. And particularly relevant in a man like this, because we have to kind of compensate and try and develop some form of guidance that he really does have group function instead of disclusion. And you can develop it accurately, and particularly if we're going to zirconia where I can't adjust it in the mouth, I need to develop this effectively. So, no, not just a toy, but an effective tool. Not just cool, but incredibly useful. So we have started to play with that. And just look at the different aspects we have. Henry talked about developing the abutments beforehand. I could have developed them beforehand. I can actually take them at this point in time and redevelop the soft tissue form by inducing pressure at different areas and modeling that soft tissue with the abutments all developed on the digital aspect. No real model. Kind of interesting development with time. And then we still like to transfer all of that back into an analog. So we're going digital back to analog. It seems like a reverse, but it's a point in time we're still looking at getting used to, as I said, the virtual one. Real key, none of our impressions are accurate. Not some, none. None are accurate. If you have these many, you will not get an impression that goes down passively. So we do bite verification, but it's really implant verifications for the head of those fixtures. This acrylic, we used to just tie acrylic across, remember, with dental floss and add. It's really not accurate enough for this. So we make the acrylic in advance, we slice it, they actually replicate teeth, we put them in the mouth. This acrylic must be somewhere in about 2 weeks old. It's best kept in a cool environment. We then add it with patent resin, and it's kept cool, and then we remake the model. And quite often all we have to do is mill out, core out 1 or 2 of these until we can replace the abutment, the analog back in the model, just in a bed, a small bed of patent resin. You can see how, in this particular case, what Guy has done so effectively, because it didn't go down, is we took out these original analogs, we core it out, we place them back on that bite and implant verification, put them back in the model, and then lute them in place, this time not with stone, but with a little patent resin. Remember, the impression material is not accurate. You generate a model, it's plaster, it's not accurate. From that, I mill a CAD CAM, or I have zircon, in this particular case, full contour PMMA acrylic. And you can see what it looks like. It's really homogeneous, it's amazing, acrylic, and it's milled. And this is a key issue. We put it into the mouth, we adjust for function and aesthetics. And the key issue now is the patient wears it for a time. You've then got to do several things. You've either got to take this and re-impress it after they've worn it, you've adjusted it, because the new one that's going to be replicated shouldn't be on the original. Remember, you made adjustments to this. You can take it out and scan it, or you can have two of them and put one in the mouth, let them wear it, that's the one that's functioning, put the other one in as an interim prosthesis, and they'll make you two. Or you've got to return it for a short while they scan it. But it has to go back. That's real crucial, because when it comes out in zirconia, you're not adjusting it real easily. Oh, sorry. We replicate this now in zirconia, incredibly accurate and monolithic. No cutback on this gentleman, just minimal, just on the direct label, as you can see. We do some of the staining. These are the water-based dyes, but they're alcohol-based underneath. And this is kind of exaggerated just so you can see where we're placing it. And then we go through the sintering process. The sintering obviously locks in the color, but the big deal is you get a very definitive percentage incremental change so that it now fits, because this is much bigger and comes down to a much smaller size and incredibly accurately during that sintering process. Spruing is all important, because as it goes through the sintering process, this will deform, so it's got to be done incredibly slowly. This is what it looks like when it first comes out, with a little color in it, and then we go through the process of minimal labial build-up and fill in the pink to create, that illusion of aesthetics. This is the whole case as it comes back. And now we've got to go ahead and nest the individual titanium bases accurately into this monolithic block. And they'll do that for you once you've verified it. And they put them in with multi-link Panavia or something like that. Usually we're using multi-link. And this is what the case now looks like with all your individual titanium inserts, bases in it. So screw-retained final case. You can see where we fill in all the individual little holes just with essentially, Teflon tape, plumber's tape, all the way at the base, and on the top, just a little composite to make it look nice. And he's functioning for the most part, because we did it digitally, on areas where we're beyond the screw holes, so we don't really chip it there, we hope. I mean, this man is an amazing man. I think it was Lenny who used to tell us, teeth are a weapon.
Yes.
And on the lower, quite interesting, two natural teeth on either side remain, periodontic compromised, but we hope give him some tactile sensation. And then, of course, the original 6-unit bridge on the lower. And Maurice's x-rays are much happier at this stage.
So when we take a look at this case, you can see how some of the things that we incorporated were certainly modern and advanced and digital technologies, using all of them. But in the end, we continue to rely upon our own, what we call sixth sense. That sense of experience, the sense of understanding the diagnostic aspects, understanding why the teeth were lost originally. Maybe in this case, the selection of non-splinting, the entire segment, the material selection, may have been the areas of weakness. So it really comes down to the dentist not being just carpenters and being interested in the technologies, but understanding the patient and the environment they're working on, and being involved in the decision-making process with the lab, not just relying on the lab to make all the decisions for them in terms of the number of units splinted and the materials that we use. You can see here again, excellent bone to implant maintenance around all the implants here in the maxilla. So certainly this isn't a perio implant related issue. It was really a parafunctional issue with this gentleman from the beginning, over-engineering the case, using a different material that's much stronger and splinting all the implants and over-engineering the case. So rather than 7 years, hopefully this gentleman will be secured with this restoration for many, many more years to come. The alternatives for us are always very, very important. CAD-CAM full contours, David mentioned, maybe in this case, if you're really concerned, maybe a PMMA acrylic prosthesis over a framework may have been another option. So there are alternatives, and also depending upon what's in the opposing arch. As David mentioned, the combination of proprioception with the natural dentition certainly should be an advantage for us to maintain his restoration for many years to come. Soft tissue indexing, being able to utilize this to gain a framework, is also very important to us.
So in this particular case, my sixth sense tells me have something ready. And what we're actually doing over here is we're scanning the same impressions again, and I'm doing this with Atlantis, and I'm going to make a chrome cobalt base in this. So we scan it, we develop a chrome cobalt base with Atlantis. It's going to be cross-splinted again, and I've got now no interfaces with, Multilink, Panavia, or anything else. So it's really incredibly solid. I'm covering all bases. Of course, I'd love to have something on top of this has a little give, so we're going to play with something perhaps a little different to ceramic, and what we're doing over here is we're doing a ceramic-filled composite prefabricated little occlusal buckle restorations. Gives me much easier to adjust them at this stage and to replace them, because it falls off, I can make another one on. This is actually Visioline. We put them on with an index that we just copied from the original case. Remember, we planned it all. These slip into it, you put them on, you develop the metals, and then attach them to it. Going through the process here, Guy is doing it, and we get, very much the same restoration all over again. And this is what he looks like as we go through the process one more time.
So really being able today to have a backup is very, very important as part of a team. Obviously today for David to be able to ensure the fact that if something did go wrong or something broke, being able to copy it and generate something that would be available as an emergency, as an insurance policy, is going to be part and parcel of these very, very complicated and expensive cases that we're doing for these patients to keep them in a restoration, as he said, for a lifetime. This gentleman obviously quite happy with the final result. Hopefully in this one, we've selected better in terms of material selection, in terms of splinting, and in terms of over-engineering the case. For us, again, it comes down to selection. We have to be part of that. We have to be part of the decision-making, both myself, Henry, David, Guy, Christian, whoever's in the laboratory with us, and make sure we make those restorations complete.
One of the things we wanted to do this morning is to start out the day and actually start out the meeting with really how we as clinicians go through practice, how we go through the workflow of actually seeing the patient, making our documentation, doing our imaging, both photographically as well as CBCT, getting our diagnosis, digital planning and design, and with all that and digital solutions that you've seen in many different ways. But we also want to say that with all that digital workflow and practice management that we're incorporating in our practices, there are still failures. So over the next 3 days, we're not just going to talk about our best cases and the great speakers that we put together. We're also going to talk about problem management and getting through some of the failures that we all face as clinicians. So we wanted to set up the table, yes, for innovations, for solutions, but also for patient management, case management, and bringing out all the possibilities and options that we have to play with. And you'll see many different ways, the same types of cases and challenges being addressed in many different ways depending on that particular clinicians and teams, options, and their resources that they have available to them. So we thank you for your attention, and we look forward to a great day to share with you. Thank you very, very much.